over the internet. I've done some interesting cases in the last couple of months, but this one has been the most rewarding. It's just been fun. This was a child that we treated at the core seminar in Las Vegas, and I know most of you obviously weren't there, so I figured it would be worthwhile to repeat it or to go over it in detail here because we have some follow-up. The patient is this adorable 20-month-old girl. She was born with craniosynostosis. What that means is that the central cranial suture was fused at birth. That's the suture that runs between the frontal part of the skull and the two parietal sections of the skull, so it runs right down the middle. That suture was fused instead of being open to allow for growth of the brain. So at 3 months, her head was football-shaped, and she had headaches, and her brain was getting squished. So the surgery that they do for this is an endoscopic surgery. It was performed when she was 3 months old. So the endoscope is inserted. They drill a little hole in the skull, and they put this endoscope, it's like a fiber optic gadget with equipment on it, inserted between the skull and the dura. So that imagine this fiber optic thing. It's kind of like doing a laparoscopy, but it's a cranioscopy. It's between the skull and the dura, so they're not inside the dura. They're not on the brain. They're on the skull. And so the bone along the fused sagittal suture in the center was removed. I should have put pictures, but if you're following along, you can Google cranial sutures and see what they did. They removed the strip of bone that was fused in the middle, and then they cut 2 little notches, wedges of bone removed from the skull between the frontal and parietal bones at the coronal suture. So within a month or 2 after the surgery, her head was normal shape, had normal growth. However, her parents contacted me because she appeared to be in constant pain. She cried a lot, never slept through the night, and the not sleeping through the night is a clue that will help you in a little bit to understand one of the treatment choices. So she was getting Tylenol or ibuprofen 2 or 3 times a day, plus homeopathic remedies. Her dad works with chiropractors and naturopaths doing IT, doing computer technologies for alternative medical offices, and mom is an anesthesiologist. So they are medically trained and adept, but they prefer alternative medicine. So one nice thing is the child has not been vaccinated. So we did not have that as a confounding piece of the history. But her behavior suggested that even with these medications, she was still in pain. She never slept more than 2 hours at a time. She did not sleep through the night. She never slept in her own bed. Her verbal development was below normal for her age. Her physical activity suggested that she had restricted range of motion. She didn't turn her head, but turned her whole body, her trunk and her head when she wanted to look side to side. Her mom said she never crawled, or at least didn't crawl much prior to walking, so she would pull herself up, but she walked not quite on her toes, but very stiff-legged, and didn't do a lot of the physical activities that a child her age would normally do. And her affect was sort of grumpy, layered on top of the normal childhood cheerfulness that you expect from a 20-month-old. So this is what she looked like when she came in. You'll have to look at her face after as it was after the treatment to see if you can notice the change in her cranial organization. But you can see that her head is normal shape. This is mom, anesthesiologist, and this is dad. And what he's got in his hand there are little puff balls, and a little plastic container to put them in. So we played a lovely game of taking the balls out and putting the balls back in. This is how we got her to move during the treatment. So, causation. What is causing the pain, right? She had the surgery. Your skull isn't being squashed. Why is this child in pain? What is causing the restricted range of motion? And then what effect does the pain and the restricted motion have on the brain, sleep, and verbal development, right? And then how do we treat it? So we develop a hypothesis with FSM, right? What's the cause? What's the problem? Why is the motion restricted? What effect does that have on the brain, sleep, and verbal development? And then you decide, after that hypothesis, how do you treat it? So I'll walk you through what I was thinking. The affected tissues between the skull and the dura. So you've got the inside of the skull, which is periosteum, right? Oh, I left off connective tissue. So periosteum is 783. In between the periosteum and the dura, there are blood vessels. Actually, the pia has lines the brain and the spinal cord. So the pia is right up against the brain. The dura is up against the skull. The arachnoid is in between, but it has little granulations that absorb fluid and help transfer the craniosacral fluid around the body, around the skull and the spinal cord. So 443 is the dura, 474 is the arachnoid. You can take the investigational eye off of the dura because we're pretty sure that is what it is. The arachnoid, it's been around for 15 years and I'm still not sure it is what it is, but it's pretty good response to it. 474 is the arachnoid. 482 is the pia, which is right up against the brain. So the spinal fluid is 288. Blood vessels that feed the dura and the brain are 62. That goes inside that space between the skull and the brain. And then there are nerves that innervate the scalp and the skull. So 396 is nerve. There's a frequency for the scalp. I think it's somebody look it up. I think it's 189, 187, 189. I think I treated that as well to treat the scalp. I forgot to import that slide. So on Sunday, the end of the day on Sunday, that's when I had them come. It's 6 o'clock at the end of the day in the core. So in Phoenix, the core was Friday, Saturday, Sunday, Monday. So this is day 3 when you've had a fair amount of physical medicine and you've seen the ability of 13 hertz to relieve scar tissue. So my hypothesis was that the surgery caused scarring between the dura and the skull. Now, when they went in there with the endoscope, they would have clamped off or cauterized any bleeders, but a little bit of bleeding is inevitable. There's no way to avoid it in any surgical situation. And any place that there is bleeding, there's going to be scar tissue. So my hypothesis was that the scarring in the dura and the associated structures, so the pia, the arachnoid, all of that, causes restricted motion and pain. So the restricted motion, why would the motion be restricted? So if your dura is adhered up in the skull, it's going to be adhered down in the spinal canal as well. So is your cerebellum going to let you move your pelvis, your spine, bend your spine, turn your neck? If this dura, which is a continuous sleeve around the skull and down the spine, is the cerebellum going to let you turn the neck, which will cause the dura to need to move or stretch? I don't think so. So she doesn't do that much. And then the fact that she has kind of a constant headache, if you think about where the dura attaches behind the eyes at the base of the skull, thank you, at the base of the skull, she would have a constant headache. And Mom said that she would grab at her head sometimes and pull on her ears, and that suggested that the pain was indeed in her head. So the other hypothesis was that pain caused sleep and mood disturbance. So she was grumpy because she was in pain all the time. And anytime you're in pain, especially if it's centralized, it's going to be worse at night when there's no competing information to interfere with it. And the pain projections are go from the thalamus, where the pain is going to be registered, into the cortex, and basically tell the cortex that there's an emergency, such that the cortex doesn't have to worry about vocabulary or words. All we have to worry about is the pain. So this centralized pain syndrome, this central sensitization, she's 20 months old. She's been in pain basically since she was 2 to 3 months old, as the brain started to grow and her skull started to change shape. So that's my Sunday treatment plan. So the treatment goals were to eliminate the scarring between the dura and the associated structures, reduce the pain, and then treat the pain processing centers of the brain to modify the effects of the fact that she's been in pain for 17 months in the life of a 20-month-old, so most of her life. So basically, the child was seated on Mom's lap, and I started out with just 13 and 443. Dad did a great job keeping Hannah is her name, keeping Hannah occupied with the toys and keep her from being bored. She had to get over being shy. She was sitting in front of a room of about 30, 35 people. We obviously you can't put sticky pads on a 2-year-old. It's just not going to work. They won't tolerate it. So we put the pads on Mom. We put the red pad, like the frequencies still needed to mix, right? So we weren't mixing them in a wet towel. We were mixing them in the mom. So the red sticky pad, put an oval sticky pad on the right side of Mom's neck, and put the black lead on the back of Mom's left hand. Green lead sticky pad on the left side of Mom's neck, and the yellow one was on Mom's right hand. So that X that we have to make with channel A and channel B was made with Mom instead of a wet towel. So then Mom put her hands, we dampened her hands with a little bit of, we had a spray bottle, and placed her hands on the child's abdomen and back. So if you think about scarring in the dura, now our hypothesis is that the dura is adhered up here in the child's skull, but that the adhesions are conveyed, if you will, throughout the spine. And if 13 hertz is the frequency to reduce scar tissue and 443 hertz is the frequency to address the dura, then it's going to address the dura no matter where in the body you put it. So we just had Mom put her hands on the baby's abdomen and back and sort of steady her as she was on her lap, and let that work for a few minutes. And the movement, right, anytime you're treating scarring, you have to move. So the movement was accomplished by just the normal activities of a 2-year-old who's getting used to the crowd that's watching, getting used to the environment. Pretty soon she's starting to wiggle around. She's happy to stay on Mom's lap. She didn't get totally stoned quite yet. And then as the range of motion increased, I stayed on the frequency for the dura for probably 20 minutes. After about 10 minutes, we added the concussion protocol, and I'll show you those applications in a minute. So as the range of motion increased, after it was clear that the frequency for the dura was working, because the first thing that changed was her neck range of motion. She was willing to turn her head. She could turn her head without moving her trunk. That was the first thing. Then she would look down at her feet, and then she started curling her spine, but she was pretty much fidgeting the way you think of a 2-year-old fidgeting. Then we added the frequency for the, so you see how her head is down. When she first came in, that wasn't the case. She had her head up. Pretty soon she's looking down at her feet, and we're playing with the puff balls. And you see that we've got this machine back here set with the sticky pads on Mom's hands. You can't see the sticky pads on her hands because they're on the kid's abdomen. And after a while, I switched to 783 because the dura is going to be adhered to the periosteum, right? What is the dura going to scar down to? The periosteum. And then it's reasonable to suspect that there's connective tissue between the dura and the periosteum. There are blood vessels between the skull and the dura. 482 is, which one is that? The arachnoid? Yeah, I don't keep these in my head. It is, yeah, 482 is the pia, the one that goes right up against the skull, the brain, right up against the vein is 482. 474 is the arachnoid, which is has these little invaginations that absorb the the spinal fluid. And then there are little cutaneous nerves at the base of the skull, so the back of her head was pretty sensitive. So we treated scarring in the nerves. I don't think I did 40 for quite some time. And then this is about 60 minutes into the treatment. You see what she's doing? She's taken off her shoe, left shoe, and then she's putting on the right shoe. And this is a dural stretch. Oh, there's her right shoe. She's putting on her left shoe. So you see she's got her hands on her foot, and she's tilting her head back. Now, ultimately, she would have her head down in between her feet and her head chin tilted forward. But when you stretch the dura from the bottom, she's going to tip her head back initially to relieve the dural tension. So this is basically treating dural adhesions. You'll do the same thing in an adult, but you can do it more voluntarily. You don't have to depend on random actions. The key with treating adhesions in the dura is not to push it. When you feel resistance or tightness, just stop. And she did exactly that. She'd go from this position, back to this position, back to this position, and ultimately her range was full and obviously pain-free. So then, actually about 10 minutes into the treatment, so it was long before we got to this stage, but about 10 minutes into the treatment, I wanted to treat the brain, obviously. Now, this is a picture of her being treated at home by Mom, but we did basically the same thing at the class. We taped one of the magnetic heads onto her jeans, and we slipped the other one into the base, into her waistband, in her diaper. So we had the magnetic converter running the concussion protocol first, and that made her pretty quiet. So that was fun. She did well with that. So we have one unit running the concussion protocol, the other unit running scar tissue as she's moving. And then concussion protocol takes 27 minutes. And then on another precision care, we swapped out the auto care for precision care, and we just did 40 and 89. So think about central sensitization. Central sensitization is what happens when anybody has been in pain for a prolonged period of time. The thalamus gets sensitized. I had to assume, or I didn't have to, but I did. I assumed that the thalamus would have been sensitized because she'd been in pain for 17 out of 20 months. So around 40 and 89, and that was the first time she became completely still. She stopped blinking. She laid back on her mom. She just got totally dwarfed for about 30 minutes. And that we used that opportunity to treat the other brain parts for inflammation, just to quiet down the activity. So 40 and 89, 20 and 90. 20 is pain reaction, the effect of pain on a part. So 20 in the forebrain. Maybe the pain has something to do with why she's not developing language as you would expect a bright 20-month-old to do. Hang on one second. Yeah, as you would expect a bright 20-month-old to do. So we ran that actually for about an hour. This whole treatment was close to 2 hours. And at the end of it, she was giggling. She was playing with her feet. We realized that we were finished treating when she was able to bend over and put her head in between her feet. And then, sure, she reached down. You notice that, remember, she took her shoes off. She reached down, and this right foot that didn't have a shoe on it, she pulled her right foot into her left groin to take off the shoe, and then she pulled her right foot into her left groin to put the shoe back on. And then she stretched her foot straight out to let her dad put her shoe on. And then she put her left foot into her right groin to put the shoe on and off. So it was a game. It was put the shoe on and off game. But her mom commented, she's never done that. She's never, you know, the thing where babies will put their feet in their mouth, or they cross their legs and they'll pull one foot up. That motion stretches the dura. The dura attaches down at the sacrum and the coccyx. And if you're going to put your right foot in your left groin, you have to tilt the pelvis and rotate it, which puts maximum stretch, if you will, into the dura. And this movement wasn't possible for her prior to this treatment. The thing that was the most bang for the buck was 13 and 443, basically. But all of these other frequencies were the ones that we used. So that was Sunday. She slept through through the night, Sunday night. She had a dose of Tylenol at 2 o'clock, and then the treatment was at 6. Tylenol lasts about 6 hours. So by 8 p.m. when we were finished, 8:30 we were treated till 8:30 when we were finished, the pain meds had worn off. She wasn't grumpy. She was giggling. She was running back and forth. This is on Sunday night. She was running back and forth, didn't climb in people's lap, running back and forth, playing, bending over, squatting, putting her butt down on the floor in between her feet. That's not something she'd done before. So Wednesday when they came, we had this follow-up. She slept through the night Sunday, Monday, and Tuesday, and I treated her Wednesday afternoon and did basically the same thing. We had the same setup. Ran the concussion protocol again, treated a bit with 40 and 89, treated scarring in the dura, the nerves. The scalp is 189. Kevin, look that up for me. So that's the scalp. So if they're going to cut a hole right in the bone from the inside, you can guess that the scalp is going to get adhered to the skull as well. So add 189 to this line of frequencies, and 443, of course. So so that was Wednesday, and then Mom sends me follow-ups Well, this was a Wednesday outcome. It was my day off, and we were setting up for the advanced, and had my Snoopy shirt on. And at the end of the treatment, she reckoned as how I could pick her up. So that's Hannah after the second treatment. You see that? See the face? Can you see the difference in her eyes compared with the first picture that we took before the treatment? Her forehead is a bit higher. Her eyes are a little bit more wide open. That was the biggest shift. So Mom and Dad purchased a custom care and a magnetic converter because they'd seen them work and they wanted to have the ability to treat at home if it was needed. So I programmed it with basically what I used during the treatment: 40 and 89, the concussion protocol, sleep, emotional relax and balance, and all the scar tissue. She sleeps through the night every night. She sleeps in her own bed. She's had no pain meds since the Sunday afternoon at 2 o'clock. Her vocabulary, Mom says, has roughly doubled. It's just expanded dramatically. She's very verbal, and she's very active with normal range of motion. What's interesting is this is Hannah getting treated with the converter. So she's getting treated on Mom's lap, but she basically picks up the bag that the converter and the custom care live in, and she drags it around the house over there to play with Dad, puts it over her shoulder and hauls it with her so she can treat herself, and then she climbs into Mom's lap to get treated. So what's interesting is that, to me, is that it wasn't that complicated, right? Once you understand the mechanism of injury, this relatively simple, this craniosynostosis, the surgery to open up the bones. So you know what tissues there are because you have netter, right? So you have the scalp, the skull, the periosteum is pain sensitive, the dura, the blood vessels between the dura, connective tissue between the dura and the skull, the 3 layers of the dura, and then the length of the dura, and then the rest is just like watching grass grow. Mostly it just took 2 hours. It took 2 hours to do that, for her to move and give herself her own dural stretches and get the adhesions relieved. I think on the second day, the Wednesday, I did some cranial work. So I reached down on her forehead and pulled the frontal bone up and tugged on her ears, just a little bit of pressure on her ears a bit, and did kind of cranial adjusting while you're dissolving the scar tissue. So this is the case. This is it. And because there's a custom care and a magnetic converter, the family has the ability to treat not only her, but Mom and Dad at home anytime they need it for maintenance. And when you think about it, she can have relief anytime she needs it. And when you think about what her life would have been like, it is forever different because of FSM. And the cool thing for me is that any one of you that are listening could have, probably would have done roughly the same thing. Maybe not in one visit. Just because I have so much mileage doing this, I have confidence in my assumptions or my assessment of what the pain generators are. But ultimately, I think everybody that's listening would have the ability to perform this treatment successfully, okay? So that's the first case. Now, the second case is one that was also covered in the advanced, and since some of you were not at the advanced, I'm going to cover this one here because it's just a good reminder. So frequency-specific treats Myofascial pain and scar tissue, it's a piece of cake, right? We treat myofascial pain. When we treat myofascial pain and trigger points, we treat the nerve, we'll treat the disc and the facet joints, then we treat the muscle. So for best results, you always treat what's causing the pain, what's causing the muscles to be tight, and what's causing the muscles to have trigger points in them, okay? That part you all have been doing since you took your core seminar, if you're treating myofascial pain. But what do you do when that doesn't work? So doing the basics, doing the easy stuff, I figure you can figure that out yourself. But what do you do when that doesn't work? That's where the thinking part of this, the puzzle solving part of this, comes in handy. So the patient said, my vagina is scarred from a tear when I delivered my second child. The episiotomy, I tore and I had a bad episiotomy, and the episiotomy is so painful, I haven't been able to have intercourse since his birth 18 months ago. Can you help me? Well, I've treated bad episiotomies and vaginal scar tissue before, and it's really easy. It's like dissolving any other scar tissue. It's easy. So we put one glove behind the patient's sacrum. The other glove, I put a latex glove on my hand, a graphite glove on my hand, PVC glove on my hand, and a little bit of KY jelly on my index and middle finger, and inserted my fingers into the vaginal opening. The vaginal opening was normal, but as I palpated posterior wall of the vagina, there was no episiotomy scar. There actually was no scar tissue. So I thought that was interesting. Now the current at this point, you can see the machine and you can see that the current is conducting. You get the conductivity bars, and I was basically just running 13 on A and 19 on B, which is the frequency for the vagina. So I inserted my fingers a little bit further, perhaps, because the vaginal scar tissue was further in, and there was no vaginal scar tissue, but when I reached the pelvic floor muscles, they were exquisitely painful, like just barely touching them, and she levitated, like came up off the table a bit. They were exquisitely tight to the point where you would have described them as being in spasm and very painful to the touch. So I went to pelvic floor muscles are in spasm and painful. So treating the nerve, 40 and 396, 13 and the fascia, 142, 46 the muscle, 62 the muscle belly. For scar tissue and hardening, 91, did absolutely nothing. Inflammation in the nerve did absolutely nothing. Dissolving the scar tissue did absolutely nothing. 13 and 77, 13 and 19, 13 and 142, 13 and the nerve. None of the things that you would expect to cause the pelvic floor muscles to be in spasm and that painful to touch, none of them worked. It's like, So as I'm sitting there with a little bit of sweat on my brow, the patient was talking while she was being treated, and she was telling the story of how she got this episiotomy. My first child was born early and was in intensive care. My second child was born 10 months after the first child. So her first child was born early, was in intensive care. And then she said, so what do you do when your kid is in neonatal intensive care? You go home and you have sex with your husband as a distraction and comfort. And so she was pregnant with her second child before the first child was out of ICU. And then she said, my uterus never had time to recover. And then you know how people will repeat the story because they just repeat the story? So she repeated the story again. And she said exactly the same thing again. My uterus never had time to recover. Now the question that's going through my head is, how do I fix these muscles that are in spasm? Question is, why were they in spasm? Okay. The cerebellum regulates muscle tone. It's kind of like when you're treating the suboccipital muscles. Is the cerebellum going to let you relax the rectus capitis posterior minor when it is attached to the dura? No. The cerebellum will tighten that muscle to prevent it from moving. Will the cerebellum let you elongate or stretch the psoas when it's glued to the ureter? No. Cerebellum will keep it short to protect the ureter. Cerebellum regulates muscle tone. Then the question is, okay, what is the cerebellum trying to protect? It's right in the rectus capitis posterior minor, it's the dura. In the psoas, it's the ureter. What's the cerebellum trying to protect? By tightening the pelvic floor muscles and preventing intercourse. Look at the anatomy. Here's where my fingers were in the vaginal opening, but these are the muscles that I'm feeling, right? The pubovaginalis, the pelvic floor muscles, the pubococcygeus, the ilococcygeus, what's this one? Transverse perineal muscles. These were the ones that were in spasm, exquisitely painful. But what's beyond them? Uterus. And then the patient said, my uterus never had time to recover. And it's like, well, recover from what? Well, if you're going to treat the uterus, we're going to do the basics, right? So I switched to 294, remove trauma, 294, from the uterus, expecting to do that whole sequence before anything happened. Well, as soon as I put in 294 on A and 34 on B uterus, the pelvic floor completely softened. Like it just went smush. The pain went away, the tightness went away, the tone went away, and I had treated both sides with scarring in the nerve, scarring in the fascia, scarring in the muscle, inflammation in the muscle, and removing trauma from the uterus made all of these muscles turn to pudding. So 294 in the uterus, completely relaxed pelvic floor muscles. I did 321 and 9, and I think I probably did 40. The next, she reported a couple of days later that intercourse was completely pain-free. She hadn't had intercourse in 18 months, so it was completely pain-free. And they wanted a third child. Her third child is now 2 years old. So this case was years ago, but it illustrates a really important point about how you think about FSM. What is causing the problem, right? If it wasn't the muscle and it wasn't the nerve, then where do you go? Doing the obvious things I assume you can do after the core seminar. Treat the nerve, treat the muscle, treat the disc, treat the set. I assume you can do those. But this way of thinking is what's important for you to kind of come to the next level, and that's what these webinars are designed to do. It's not about the frequencies, it's about how you think about them. So think about what we're doing with resonance, right? Trauma is a pattern that's stored in the tissue. The body responds to the pattern. Protect the uterus. Let's not be doing that pregnancy thing again. And when you remove the pattern, the tissue changes. And we remove it with a signal. There's literally no other thing you could have done. I mean, I guess you could have injected her pelvic floor muscles with Botox, but that sounds gruesome. And I'm not sure it would have worked. Also, it would have interfered with normal bladder control and pelvic floor function. So the frequencies did just an amazing thing. This concept that we use, this principle that we use, biologic resonance, the frequencies are like that key fob on your keychain that opens the door lock by changing cell signaling and function electromagnetically. Okay? Now with Hannah, we assumed that the pattern was scar tissue. And we changed the pattern of scarring, the bonds that held the scarring in between the skull and the dura and the blood supply and the nerves and the scalp. We changed that pattern because the scarring was the cause of her pain, and we had to treat the pain effect on the brain. But when we're treating the uterus in this patient, the pattern was trauma in the uterus that caused these pelvic floor muscles to be tight. So those are our two cases for today. I'm going to bail on you a little bit early. I have about the stamina of a kitten, to tell you the truth, but I'm doing pretty good. I just want to remind you that we have new FAQ brochures. We finally updated both the graphics and the inside. They're a lot easier to read. It's much more pleasant. We sold out of them at the advanced. We have more here. The information is updated, current and accurate, easier to read. Be sure and get them out in your office to explain to patients what you do with frequency specific. We also have, if you don't have stickers to put on your window or your office door telling people that you do FSM, be sure you let us know, and Kevin or Brittany can send those out to you. We are still working on the website practitioner list subscription process. The website's ready to go. We just have to implement it on our end and send you all notices. I confess that we're a little bit nervous about it because I don't want to lose our whole practitioner list, but we need to get the practitioner list accurate, and it's not. So we're going to send auto renewal notices or renewal notices. It's $89 a year. You'll make that back in the first patient that finds you, because patients will find you if you're on the list. But we have to get the list accurate. The resonance effect is selling like hotcakes, so to speak, and the word is spreading. So the other thing we recommend is that you have the resonance effect in your office to either sell or give or lend to patients, so they know what you're doing and where it came from and how it was developed. Most patients really like the book. It's really easy and it's a quick read. So watch for this practitioner list subscription notice coming out. Do we know when? I have to keep.
I'm testing right now, so.
Kevin's testing right now.
If you accidentally get an email from our test, sorry.
Yeah, well, and it's basically I have to stop putting him on airplanes or in seminar rooms because we're leaving for Chicago for the Forum for Integrative Medicine on Thursday, and then the weekend after that is the core seminar. And then after that, I'm out of his hair because I'm headed to Taiwan with Kathleen and Katie Kasdan to do a course for the Physical Medicine and Rehab Association in Taiwan. Taichung City at the hospital. As you saw with Hannah, the pulse EMF works. The magnetic converter doesn't have a CE mark, and it also doesn't have a 510K. It is a low-risk device that Dr. Flick says do not need to be registered with the FDA. But it's effective for most conditions, and it's useful in situations where you don't want to put another device in a wet thing or a sticky thing on patients. We're using it for wound care, and particularly for long treatments. PTSD and post-op care are probably the best. I have a feeling it's not going to be useful for treating the nerve or the spinal cord. So 40 in 10 patients, 40 in 396 patients, it may be of limited usefulness. I don't have enough mileage yet. And I just wanted to brag on Jody Adams. As you know, publishing case reports is what we have to do before we can even approach anybody for controlled trials in particular conditions. So the Research Foundation went away for various reasons. And so the thing that we can do is reward or induce, I'm not too proud to call it bribery, reward, induce, encourage practitioners to publish case reports, and any publication in a peer-reviewed journal of a single or a collected case report will be given a $1,000 check. Jody Adams at the Advanced received a check for $1,000, and I'm hoping she did something fun with it. The paper she published was Frequency-Specific Microcurrent Resolves Chronic Pain and Adhesions After Ulnar Transposition Surgery. It was an online journal, so not the top tier, but it's indexed and abstracted. It's not Medline indexed, it is abstracted, and it's available on the internet if somebody's searching for adhesions. The Journal of Novel Physiotherapy and Rehabilitation was published in January. And that's the thing. I don't have a limit on how many of these we'll give away. I have a little nest egg put away that we will use to give people these prizes. I'm looking forward to giving out multiple ones next year at the Advanced and Symposium. And I encourage you to, this case was simple. She had range of motion and TAOs, their functional medicine, functional scores, like activity scores. It's kind of like an oswestry, but for extremities, for function. She had those scores before treatment. She had his medical history, 7 years chronic pain, 2 episodes of physical therapy with no resolution of pain. Pain was getting worse. And basically it was 2 treatments. Because we delayed the publication for, I think, 4 years, we actually had a 3-year and a 4-year follow-up with him, documenting both the pain score and the range of motion and the TAOS evaluation. So that's all it takes. Something objective like a pain score, a TAOS score, or an oswestry score, and the range of motion. And if you do a collected case report, Walter Gregory will help do the statistics, documenting the collected cases and giving them statistical validity. I wrote the method section and helped her write beginning. I have a research assistant that will help do the literature search. So everything you need to publish a paper is right there. And then there are so many online journals or even standard medical journals that are looking for contributions in the area of alternative care, especially when it comes to pain management. These days, they're trying to get everybody off opiates, and we have an answer. So we have, one small collective case report in neuropathic pain. I encourage somebody to replicate that. I need other people besides me publishing these cases. So it's worth $1,000 to you, and we will help with the cost of publication if there's more involved in that. This is important. This is how we will survive, and it's how we go forward with FSM. Diabetic neuropathies. We need a collected case report with diabetic neuropathies, either pain or wound healing, before we can even apply to do a control trial. Shingles. Any condition that you're treating, neck pain, shoulder pain, low back pain, you name it, you can publish a paper about it, and you can go on a relatively nice vacation for $1,000. So I encourage you to take advantage of this and give me somebody to give checks out to next year. The Advanced will be back in Phoenix, and the symposium on April. I don't remember the dates. Look at the website.
Which one?
Advanced and Symposium next year.
Oh, geez.
Yeah, we forgot. Anyway, it's on the website, and so that's it for today. It's 5 o'clock. I'm gonna go take a little nap. Basically, you guys are changing medicine, and you're doing it with every patient you see. And as you saw with the woman that had the baby, right? She had her third child. It changed their lives. It gave that baby a life. With Hannah, changing her life and her parents' lives, right? And you can be that one practitioner. I keep saying it's not important that I can do things. What's these things? What's important is that it's teachable and reproducible, and you can do it. Doing it is easy. The only tricky part is thinking about the fact that you can do it and how to do it. That's the trick, and that's what these webinars are for. And then think about what happens to the world, because Hannah's going to be a very verbal, active, cheerful, productive young lady. And think of how the world will change because that practitioner has 3 children instead of 2. What will those people do? How does that change the world? How does it change the world when 1 person or 2 people or 20 people or 100 people, how does it change the world when they're out of pain and can live productive and happy lives? So that's the take-home message for today. We will do a webinar, I think, next month in between trips. Do good things, enjoy FSM, and I'll talk to you next time. Isn't that okay?